Hello, and welcome to the Taking Control of Your Diabetes podcast. I'm Dr. Steve Edelman. My good friend and colleague and partner, Dr. Jeremy Pettus, could not be here today, but this is a topic that's near and dear to both of our hearts, living with type 1 and having children ourselves. Today, we're going to talk about really screening for type 1 diabetes. And we have a special guest with us today, Anastasia Albanese O'Neill, who is I should say, a very passionate person in this field because she has a daughter with type 1. She has another son named Jack, and now she's going to give you her background, but you can see that she's quite motivated and inspired to continue this screening process that is so important to the folks around the world, actually. Anastasia, introduce yourself.
I'm delighted to be here. I'm Anastasia Albanese O'Neill. I'm now with JDRF in the role of AVP and leading our screening education and awareness and clinical trial education awareness programs. But I think one of the important reasons that I work in this field at all, and you called it out at the beginning, is I have a daughter with type 1 diabetes who was diagnosed at the age of 16 months. And I think that was a very formative experience as a parent. I didn't go into healthcare until after her diagnosis. And then once I got back in school, I kept going. But we are really at a pivot in type 1 diabetes care and research. It's a watershed moment where we can do something other than monitor glucose and deliver insulin. And the reason I moved out of clinical care, where I spent about 14 years, to JDRF is I wanted to be a part of this moment in history in type 1 diabetes. So I'm excited to be at JDRF, and I'm excited to be here with you today and talk about the importance of screening and early detection and the benefits of both of those things.
Yeah, well, thank you for that. Well, there's no better time to talk about screening than now because, I'm a little bit older than you, Anastasia, and I can tell you there have been over 300 rat and other animal models of type 1 diabetes that have been cured in the laboratory with all kinds of press releases, headlines. We discovered a cure for type 1. And then when they bring that cure, quote unquote cure, to people who are human, it doesn't work. And it turns out that there is a medication, as you know quite well, called teplizumab. The marketing name is Tzield, that was recently approved by the FDA to give people who have pre-type 1, and we'll talk about that a little bit more and define that, that can delay the development of full-blown type 1 diabetes. And what that means, even for people who screen and screen negative, or people who screen and screen positive and are not involved in a clinical trial. And we know that there's over 100 people diagnosed with type 1 every day. The other important fact that will lead off our discussion of what you believe why everyone should be screened for type 1, and I'm with you, is that 80% of people who have type 1, like myself, like Dr. Pettus, like your daughter Cassidy, they're the only person in the family with type 1. Even though the screening is now a little more focused to first and second degree relatives. So with those introductory comments, I want to hear your take on the importance of screening.
Yeah, no, thank you so much for setting it up that way. So you're absolutely right. If you are in a room of people living with type 1 diabetes and you ask them to raise their hand if they were the first person in their family diagnosed, you will get between 80 and 90% of people in that room. So if we limit our screening to family members, then we're going to miss a lot of people who we could detect early and who would be able to take advantage of the benefits of screening. But let's take a second and talk about family members, because if you think about the research or the people who've participated in screening research studies in the United States, it's very new in the clinical setting. If there are 2 million people with type 1 diabetes in the US, we can assume conservatively that there are about 8 million first-degree relatives. That means parents, siblings, or children. But through the research process so far, only about 300,000 people have been screened of those relatives. If we add additional relatives of people with type 1 diabetes, meaning if we add second degree relatives, so who are they? If we add cousins and aunts and uncles and nieces and nephews, that probably takes us to about 30 million people eligible to be screened as family members. And so that's a lot of people. We're talking, 30, 40 million people that we could ask to raise their hands, step forward, and participate in screening and early detection. Why would we focus on family members first? What we know about family members is that their risk is increased. It's about 15-fold increase. So while our goal is to get to population level screening, I think a great place to start is with those family members, because there's millions of them out there who are eligible and could really help us achieve our goals of delaying and ultimately preventing type 1 diabetes.
Yes, I totally agree. It turns out that, as you know well, first and second degree relatives have a much higher rate of developing type 1 diabetes. So at the current time, our country is setting up these infusion centers to give this medication called Tzield. We'll talk about that more a little bit at the end. And I don't think we're ready for the masses at this moment. But I think what's important to say at this point is, and I definitely want to hear your opinion, is what a family goes through when they don't have any clue or idea that their loved one was at risk for type 1. They had no idea that they had these smoldering islet cell autoantibodies that were destroying the insulin producing cells of the body. And then boom, they may not have been feeling well. They lost weight, thirsty, urination, and then they take them to the ER or their doctor for kind of a semi-urgent visit. And next thing you know, they're wheeling that person into the intensive care unit for diabetic ketoacidosis. So I think screening, the benefits of screening go far beyond looking for people who could be a candidate for this monoclonal antibody that we call Tzield. And what did you go through when your 16-month-old daughter came down with type 1?
Yeah, well, it was somewhat as you describe. We have no family history. She was 16 months old. We had taken her to the doctor many times, and she kept getting a different diagnosis: ear infection, prescribed some antibiotics, viral infection, fluids, push fluids, and rest. And it's funny, Steve. It was only when we were boarding a flight, and we were flying from Seattle to Los Angeles, where we lived at the time. And we put her in her car seat on the flight and put on a clean diaper, and we landed in Los Angeles. She was soaked in urine up to her chest.
Mm.
And, that's a sign of very high blood sugar and DKA, right? Lots of urine and thirst. She was very thirsty on the trip. And I called my mom, who happened to be an attorney who defended schools, and she was familiar with DKA for that reason. And she said, I think it's type 1 diabetes. And I said, I have no idea what that is. So I looked it up in a parenting book. And in the parenting book, it had some words. I worked in marketing in the airline industry at the time. And I looked in this parenting book called What to Expect the First Year. And it said, type 1 diabetes is characterized by polyuria, polydipsia, and polyphagia. Well, I didn't know what any of those words meant either. So I got out a dictionary. Remember, there were dictionaries. There was no Google at the time. It was 2002. And in the dictionary, it said, very thirsty, very hungry, frequent urination, bingo. Made an appointment for the next morning. Just as you said, when we got to the doctor and we finally got the diagnosis right, they basically said, do you want to take an ambulance or a helicopter across town? Because she's very, very sick now and needs to be in the intensive care unit. And we spent several days there and then more time on the hospital floor. It was tough. And if I could prevent, in my role here at JDRF or in my career, any other family from experiencing that would be a win. It would be success. And as you have said, one of the primary benefits proven over and over again in the United States and in Europe and in Australia in research studies is that if we screen and monitor, we prevent DKA at diagnosis in a way that is almost unimaginable, from about 50% of the time all the way down to less than 5%.
Yes. And, for our listeners who may not realize this, but 16 months is much earlier than the average age for type 1 diabetes. And I can't imagine what you went through, because a kid that's only 16 months can't tell you, Mommy, I'm thirsty, I'm urinating a lot. I'm feeling tired, lethargic, and even after the diagnosis, they can't even tell you, Mom, I think my blood sugar is low. They can't even speak. So that is an unusually tough situation. I'll just say my my personal experience. I was 15 years old, and I lost a bunch of weight, and I was kind of a chubby kid. My nickname in middle school was the Stump, and I loved losing weight. But man, I was tired. I was falling asleep in class. I would go to the faucet in between the hour classes in middle school, and I would drink so long that kids behind me were yelling, "Hey, hurry up, hurry up." And then I would have to use the restroom and get the little restroom pass halfway through every class. So, and then finally, my mother took me to my doctor, and that was, they bring in a wheelchair right to the emergency, right to the intensive care unit. So this was a dramatic situation, and for most people, they experience that. And then all of a sudden, you're 15 years old, and they're teaching you how to give yourself shots, and they're telling you what you can eat, and mostly what you can't eat. And at the time, Anastasia, there was no finger sticks. I was peeing on a urine dipstick, which is so inaccurate. I had such an archaic regimen, and of course, the whole family's upset. All they read about is my kid's going to go blind, lose his kidneys, lose his leg, and of course, these are different times now. So, I think between your story and many others that are probably more like mine, living with type one, um, there are so many reasons to test, and you can prevent that whole dramatic episode that is so traumatic to the family. And you mentioned these European studies, and I think it's worthwhile saying a quick word that these studies just screened a ton of people for type one, and even though they may not have even volunteered for the study, they somehow got educated, and the incidence of DK went from 60, 70, 80% down to less than 10, 15%, and probably not as severe a presentation as it could have been. So I think the screening is important. And I think right now, would you agree that most organizations like the American Diabetes Association, and you'll have to tell me what the JDRF's current stance is. I know ISPAD, which is Diabetes Organization for Kids, recommends screening everybody. What is JDRF stance on this?
Yeah, so our long-term goal is universal screening. I think we want to think about, you mentioned, do we have the healthcare system capacity to screen everybody? Maybe not yet. So I think what we'd like to see is a stepwise progression to that universal screening goal, where we do it in a way that we make sure that people who do get positive results, meaning they test positive for these autoantibodies, get the care they need. And I'll point to a project that we've been working on for the past 15 months and has come to an end recently. And that's an effort to get an international consensus on what we're calling monitoring guidance. So I'm a nurse practitioner now by training. And my mentor, Desmond Schatz, who's still a physician at the University of Florida, I can hear him in my ear saying to me, Anastasia, if you order that lab, what are you going to do with the results? And what I can tell you, Steve, is until now, in the clinical literature for people who work in primary care and see children and adults, or even in specialty care, there was no guidance on what to do with these positive autoantibody results. What I can tell you is experts from 4 continents, 11 countries came together. These were experts who led the studies that you just referenced in Germany, in the US, in Sweden, in Australia, and put together monitoring guidelines, which are very specific about what do you do when somebody comes back with a positive autoantibody test result? What do you do to confirm that test? How do you care for them? How do you help them realize the benefits like DKA prevention? And how do you give them time to plan and prepare, to think about research participation, about how they're going to manage type 1, how they get educational and psychosocial support, and then if they want to take advantage of an FDA-approved therapy. So we're really delighted with this monitoring guidance. We think it's a critical step in giving people confidence to get screened, because now there is very clear direction for people in the healthcare space about how to support them in their decision-making and what to do next.
Wow, that sounds like they put a lot of time and effort into that. Keep that list that you just rattled off handy. I want to take one step back
Yeah.
and let's talk about what does the screening entail and what are they measuring and how easy it is to get screened.
That is a great place to start. And I think, we've done surveys of people who interact with JDRF, our constituents, our type 1 diabetes family. And what they tell us often is, I didn't know I could get screened, or I don't know how to get screened. So I'm really glad you asked this question. So what is happening when you're screening? Well, the good news is, thanks to decades of research, and I just want to underline the word research, we can now identify people who are in the early stages of type 1 diabetes, meaning before insulin is required, through a simple blood test. It can be a finger prick, or it can be a blood draw, like you would go get at a lab, phlebotomy. And what they are testing for in the blood is an active immune attack on the insulin-producing cells in the pancreas, the beta cells. What the body's immune system does, for reasons we don't understand, is it goes in and destroys only, in type 1 diabetes, the insulin-producing cells in the pancreas. So with this simple blood test, we can pick up 4 autoantibodies, which are proteins in the blood, that tell us that immune attack is active and underway. Anybody we detect who has even a single autoantibody, we want to get a confirmation on, and that would require a second blood test. And there are a lot of ways you can get tested for free. So let me just outline those, if you will give me the opportunity quickly.
One is don't
that
rush.
okay?
This is important.
Okay.
Yeah, please.
All right. So there's a research study that if people haven't heard of, you can go to trialnet.org. They will screen you. You have to be a family member for this. So if you're a first degree relative, parent, a sister or brother, or a child, you can be ages 2 to 45. So that's a lot of people we could screen for this free testing through TrialNet. Or you can be a second degree relative, so a cousin, an aunt or uncle or niece or nephew, ages 2 to 20. That is route number 1, is TrialNet for family members. The other thing that's free, and again will help us with our understanding of type 1 diabetes and why it happens, is a study called ASK. The ASK study will screen you for not only type 1 diabetes, but also celiac disease with the same blood sample. What's great about this study is it's available not just to family members. So this could be any child in the United States ages 1 to 17. Let me say that again. Any kid ages 1 to 17 in the United States, they will mail a kit to your home. You can collect the blood sample by a finger prick, a capillary blood sample, or you can go to a lab. So that's number 2. But the third way you can get tested is ask your doctor. The concern here is possibly payment. So we don't want people to get stuck with a big medical bill. So there is some information on the JDRF website that can help you sort of navigate screening at your doctor's office, and also help inform your doctor about the recent changes in the clinical guidelines and other information that would be helpful to them in their clinical practice.
Yeah, that's awesome. And let people know that most labs now have a type 1 screening set that includes those 4 autoantibodies. So that's, Quest, LabCorp. I just ordered one for a patient. And so it's becoming widely known, and this test is available, and it's just a simple blood test, or not that we like to prick our fingers, but sometimes that's a more convenient way. Now, the other thing is that, you mentioned celiac, and I'm so glad you did, because there's been lots of research looking at people with other autoimmune conditions, celiac, and also autoimmune thyroid disease, which is pretty common. And those folks definitely have an increased incidence of developing type 1, even without a prior family history of type 1. So I think we're becoming a little bit smarter on at least the low-hanging fruit on who to screen, just short of universal screening. So when someone tests positive, you mentioned that you want to reconfirm that. And I thought it might be good to talk about, I'll let you do this. You're the expert in this area, about how we talk about stage 1, 2, and 3, and then what to do if you're positive.
Yeah. So
and you've been confirmed, I should say, too.
yeah, no, that's great. Steve, I'm wondering if I can go back just one step and talk about, you mentioned that you can order these 4 autoantibodies through a lab, and you just did that for one of your patients. Is that right? For
Yes.
somebody in clinic? Yeah. So the other thing that really bothers us at JDRF is adult misdiagnosis. So you are probably aware, and I'm guessing some of your listeners are, that often when you're an adult, remember, for a long time, type 1 diabetes was called juvenile diabetes, but it is really not just for juveniles. So about 50% of the time, people diagnosed with type 1 diabetes are adults. And what we see in adult care is often people with type 1 diabetes are misdiagnosed, initially given a diagnosis of type 2 diabetes, not prescribed medications that will help them get their glucose levels to target. And some of them get really, really sick. So we are really keen on making sure that in clinical care, autoantibodies haven't been around for that long. Obviously, not when you were diagnosed. We weren't talking about them clinically when my daughter was diagnosed, but we are now in the past 10, 15 years. We want every clinician to know that they can use this testing also to accurately classify diabetes type, meaning if somebody comes in and they're an adult and you're not sure, test for autoantibodies, get the diagnosis right, get them on a continuous glucose monitor and insulin and an automated insulin delivery system, all these benefits that have come out of research so that they can manage their type 1 diabetes as well as possible and really benefit from these research discoveries and breakthroughs that we've seen over the past really 5 to 10 years in terms of clinical management.
I'm glad you mentioned that, Anastasia, because we know that people with celiac and autoimmune thyroid disease, those individuals are at risk for getting type 1, even if type 1 has not run in their family at all. And so it's kind of a cluster of autoimmune conditions, and one of those autoimmune conditions is type 1 diabetes. So the screening is important, and we're gonna spread our screening in addition to shooting for international screening. So in terms of the laboratory testing, the 4 autoantibodies will indicate who's at risk. So we talked about the stage 1, 2, and 3 of type 1. I like to call stage 2 pre-type 1 diabetes, where individuals their blood sugars are slightly elevated when tested, and they have 2 or more autoantibodies, and we know that those individuals have virtually 100% of developing type 1 down the road. And if you read the New England Journal of Medicine paper, that the average delay in the development of type 1 diabetes is 2 to 3 years. Some individuals that were involved in that study have never come down with type 1, and others develop type 1 earlier. So that's just the average. And so we're really at the infancy of a lot of the research and the sub-analysis. And I wanted to ask you this question because I was at the FDA hearing for the approval of this medication, teplizumab, and we had very smart people on the FDA committee saying, what's the big deal of delaying type 1 for 2 to 3 years? Other than putting up your middle finger at them, what would you say?
That is too much. So a couple things. Let me answer your question specifically first. So insulin was discovered in 1921 and first delivered in 1922. We have our Canadian colleagues to thank for that. And it really was a monumental shift and life-giving discovery for people with type 1 diabetes. The next approved drug we have had in type 1 diabetes is the drug you mentioned, teplizumab or Tzield. And while some people may say a delay of 2 or 3 years is not significant, I will sort of underline an example of just how significant a shift this is in our clinical paradigm and why it matters so much. There is a chapter in the American Diabetes Association Standards of Care that until January of this year was called the Delay and Prevention of Type 2 Diabetes. It specifically called out type 2 diabetes because we could delay or at least put type 2 diabetes into remission. In January of this year, in the Standards of Care from the American Diabetes Association, that chapter changed. Chapter 3 changed to the delay and prevention of diabetes. Why? And they don't change chapter names very often. Why? Because for the first time since insulin, we could do something to intervene and change the course of the diagnosis and delay the requirement for insulin. For people outside of the type 1 diabetes community, they may say, wow, 2 to 3 years is not that long, but 2 to 3 years is long in someone's life, and it can feel particularly long if it delays the requirement of insulin through the middle school years or through the college years. So this medication that people are eligible from years 8 and older, again, is really a landmark breakthrough, specifically or in additionally, because it changes the way we think about type 1 diabetes clinically. And I would just add that we have now 5 other currently recruiting studies looking at other drugs, and actually in stage 3, which is at a new onset of type 1 diabetes. And we have 2 studies back at stage 2 for people who screen and we detect in what we call early stage type 1 diabetes. So we have a therapy, which is extraordinary, but we also have a change in thinking about how we, in the future, will treat type 1 diabetes. And we don't just think about it as blood sugar and insulin delivery. We're now thinking about it in terms of immunology and how can we intervene early and delay that onset. And ultimately, we'll be looking at combination therapies. But this is a really exciting time. It's a really important time for people to lean in and get involved in screening so that we can achieve these goals.
Yes, well said. The way you spoke, I want you to run for president of the United States.
No way.
Anastasia, the 2 to 3 years, I'll look at it on the clinical research front. Look what we've developed in the last 2 to 3 years. Hybrid closed loop systems where the pump communicates with CGM and better, therapies. So 2 or 3 years in terms of the developments for these individuals that come down with type 1 could be way advanced. And of course, the family will be ready. In fact, we'll probably wouldn't even require an admission to the hospital. It would just be, okay, our time is now. Let's just take care of it emotionally, physically, and in terms of all the therapies that'll be needed. And you mentioned studies going on for people with newly diagnosed diabetes. And those folks, they will search out anything that's available. But I want to take one step back, and as we come to the end of the podcast, focus in on the importance of screening individuals with no symptoms. So if I was a primary care doctor, how are you going to convince me to screen individuals that do not have type 1 and even, in their practice? Because that's probably where it's going to be the most important. Endocrinologists, we can talk to our type 1 patients and give them the information about their first and second degree relatives. But what about the rest of the world?
That's a great question. And, I want to give a nod to our colleagues in primary care who do everything. They need to know about all kinds of diagnoses. They need to help all ages of people, especially if they're in family practice. And more, we're giving them less and less time to spend with individuals. So how do you incorporate screening into a primary care practice? It's a great question. Something we're working on here at JDRF is we are supporting what we're calling a pilot screening clinic program. We are supporting primary care sites to think about, is this feasible in their workflow? So we can support some time for staff members to build workflows and think about how they'll integrate this into the electronic health record. We are providing HCP education specific to this topic so that they can upskill everybody in the practice. When I first finished my PhD, I taught in the College of Nursing, and I taught advanced pathophysiology to our nurse practitioner students. I didn't talk about staging of type 1 diabetes. I didn't talk about screening for autoantibodies. That's another opportunity to think about medical education and nursing education. But let me get back to the pilot clinics. We also want to see if it's acceptable in these pilot clinics. Will people participate in these screening opportunities? And then, is there a positive effect? Meaning, as we identify people who are positive, do we connect them to the benefits of screening? So if there are primary care practices out there that are interested in implementing screening, we want to offer some assistance. And I'm sorry for the shameless plug, but I think that we need to figure out what the what the barriers and facilitators are, what is going on, so we can support this taking effect in primary care. I think also there are a lot of educational opportunities, more and more about screening. And I mentioned this was not taught in medical education, in education if you're a physician's assistant or a nurse practitioner or a diabetes care education specialist or whatever your role is in the healthcare ecosystem. I think it's a great opportunity for anybody out there listening who works in healthcare to take advantage of one of these free continuing education classes and really learn about this new state of the science and then share that information with others. So we've got some hands-on practical ways to do this, and we've got some education. And then the last thing I would say is, as you noted earlier, these labs can be ordered through the electronic health record. These tests are available at many labs, and so it can be done, but it does need a workflow and I think a clinical champion to lead the charge.
Yeah, I vote for you to be the clinical champion. How's that? And I think before I get some final thoughts from you, I should let our listeners know what does the therapy entail. And there's a lot more details that I'm going to tell you in this one sentence, but basically it's a 30-minute infusion for 14 days in a row. And you usually would go to an infusion center. They're setting up, some folks get it done at home. And so it's a 14-day infusion, but not 14 days times 24 hours. It's 30 minutes at a time. And it's very well tolerated. And we just put our first patient through the therapy with no issues at all. But I think I didn't want to focus too much on that issue, but I just wanted to focus on the screening aspect. And I think I put the part of the job of getting the word out to people living with type 1 so they can educate their friends, their relatives, and especially their first and second degree relatives, and get the word out. Because as an endocrinologist, I'm never seeing anybody that at least in my diabetes clinic, who doesn't have type 1. They all have type 1. So it's a different viewpoint. And I think we're at a different era. We're at a watershed moment. You said it so perfectly, Anastasia. What kind of words of wisdom you want to finish with? You're so knowledgeable in this area.
I just am passionate about it because, again, we are at this inflection point. It's a change. And I love what you said about talking to people about this opportunity and about the benefits. I think some people might be nervous to participate in screening. I think it's a natural human response to maybe not want to know, not want to get bad news if it's perceived that way. But screening can also result in what I kind of think of as good news. I've been screened and other family members have been screened and we have gotten a negative result. But when I talk to family members or individuals who've come back with a positive result, it's exactly what you said. We are at a new sort of era of care in type 1 diabetes. There are very clear benefits, an immediate clinical benefit of not landing in the ICU and DKA, but also these other opportunities in research and in approved FDA therapies. So this is really the time. And I think if we all lean in as a community, I think we will move the progress forward faster toward breakthrough. So I would just encourage people, I'm not going to say run out and get screened, but run out and learn more about screening, what the benefits are, make a considered decision, and be part of this process wherever you fit in and feel comfortable so that together we can get to the delay and prevention of type 1 diabetes.
Wow. I think that was the last word. Well said, Anastasia. Hey, thanks so much for coming on the podcast today. Your information is so important. You're so well spoken. And plus you live through it yourself, probably tougher than most parents of a kid with type 1. So thank you so much.
Thank you for having me here with you today. It's been wonderful. And, I think my daughter is an example of how you can thrive with type 1 diabetes. There were some hard days, but every one of them was worth it. And I'm really delighted to be able to share this time with you and your listeners. And I hope they all reach out for more information. Thank you for having me.
You're welcome. Okay, Anastasia, that was awesome.
I hope so. I hope I kind of got us off topic. I apologize. I sort of dragged you into tech.
Don't Don't apologize. I dragged you back.
You did. Well
I
done.
just realized, did we mention like where I didn't hear it, where people can go to get tested, like the screen for type 1? We did mention that. Okay, cool.
Yeah,
So
TrialNet, Ask.
Okay.
Yeah.
Cool.
Yeah, and I think also that obviously JDRF goes without saying too, and we've had articles. I mean, I think we said the important information about where to get screened: the Ask, TrialNet, and that'll get them to the right plot.
Yeah, I didn't mention they can absolutely, and I should have, it's sort of embarrassing. But they can go to jdrf.org/T1 detect, and all the screening pathways are listed there. Well, thank you so much for having me here with you today. It's been a privilege. We talked about a lot of different ways that you can get screened, and I think the pathways can sound confusing. An easy one-stop place that you can visit is jdrf.org/T1 detect. There's information there about the research studies we discussed, about getting screened at your doctor's office, and a lot more information so you can make a considered decision. So check that out.
Thank you very much, and kudos to the JDRF for everything they do for people with type 1 diabetes. You take care now.
You too. Thank you so much again.